better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hi, everyone. I'm so excited to welcome our guest to No One Told Me, the Airway Health Connection podcast. This is Autumn Henning. She is an SLP, certified orofacial myofunctional therapist. Did I say that right? There's so many.
Yeah.
IBCLC, and there are so many letters behind your name. It's just hard to keep up, truly. So let's dive in. How are you today, Autumn?
Yeah, I can't complain. I'm good for a Monday for sure.
Yep.
Yeah, thank you so much for inviting me. I know we've been partners in crime and friends for a while, so it's good to talk to you and see your face and all of that. I love this podcast that you're launching too.
It's so fun when you run in the same circles with the same thought processes, because it's like, even though, I mean, I think the last time I saw you in person was what, 2 years ago in Denver?
Denver.
And, but it still feels like I get to follow all the things you're doing, and it's like catching up with old friends. It's fun.
Yeah, totally, totally. Well,
Well,
let's,
how did we meet? That's something that you and I were talking about. And
I
I
was
remember vividly
okay.
because I was kind of newly on my oral ties journey. Like, I had a
Uh-huh.
newborn at home, and I was like, oh my, we've missed a lot in
Oh,
dentistry. Like, what
yeah.
do we need to do? And in researching courses, yours was the first one that was recommended and popped up for me. And I would say it was so helpful to hear from a non-dentist about dentistry related things, because it gave me a much better understanding just right from the get-go of how many things that you guys as SLPs, IBCLCs, OMTs manage that are beyond my scope of practice as a structuralist. So, do you remember where we were?
What? No, which
It
course?
was the Texas one.
Okay, at Texas Children's?
No, I just remember being like right next to a strip mall and getting my nails done. And I was like, I haven't had my nails done in a long time. This is great.
So I taught in Houston twice, two times, and then Texas Children's.
I think it was like
So
2018. It's been a
I
minute.
know you were like one of the
Uh-huh.
OGs.
Uh-huh.
So
Yep.
yeah,
I remember playing
early.
with the laser. It was, and I mean, I think I bought it like the next day because like this is life changing. So,
Yes.
I mean,
Yeah, you were
your
early.
background, it's just so unique, and that's really what I found with your course was there were other dentists there. It was hosted by a dental practice actually, but there were speech and
Yes.
language, myofunctional, occupational. Like, your course
Yeah.
covers so many bases, and I know you have a number of offerings now. I think that was just your TOTS course. It
Yeah,
was
that's like
before
our
feelings
flagship.
existed, everything. So,
Yeah, yeah. And
yeah.
I mean, I think my goal in that was a lot of what you said is, really when you work together as a team, you kind of have to know the other side of things, right? And so like I go and take orthodontic courses just for my like knowledge so that I can, really understand that side of things and what, patients are faced with and how that works. So I do think that's valuable. I rarely go to any courses that are only SLPs or only lactation, um, because I've just found so much value in learning from the others. Yeah, when I set out to do this course, it was meant to be for the people working on the function, right? And then y'all dentists, you showed up.
We showed up because we don't got no idea about the function is the problem. And we still don't. Like, that's what we're really hoping to change on the dental side of things is, at the end of the day, the goal is functional improvement. It's
Right.
not like how pretty your release is. It's
Right.
like what happens after is actually what matters, not what your
That's
surgical
true.
photos look
And
like.
on the therapy side of things, like we know all about function, but we were not taught about the whole structure piece and the impact on airway and the impact on dental facial growth and all of that. So, like, coming out of a master's degree, we weren't taught anything about tongue tie. And
Yeah.
so it was just like an epiphany for me when I did encounter it. And then I just started practicing and playing around with it to see what works and what didn't. And that's kind of how it came about. So,
Yeah, because tell us a little bit about your background.
yeah, so I am a speech language pathologist by trade. I joke and I tell people I'm the weirdest speech language pathologist you'll ever meet because it doesn't really describe what I do. So I live and breathe mechanics, how muscles and nerves and joints and all of that work together or don't. And so that's kind of where I love, putting all these pieces together, zooming out and looking at the big picture rather than just my little piece and looking at how it fits together. So that was kind of where I started. I say feeding was my first love. So, that's even kind of niche and rare. At least it was 15 years ago, for sure. So I had my first case of tongue tie then and kind of cracked the case, if you will. And that was like my epiphany case. And then I started, seeing these kids with tongue ties. And you talk about like, hey, this research wise, this can be related to sleep apnea. This can be related to TMJ dysfunction, um, and whatnot. And then you look over at their parent and you're like, apple tree. And, I try not to say anything. I just educate and let them come to their own conclusion. But anyway, that's when I became a certified orofacial myologist. So I was seeing like a gap, like, okay, I can help these kids, but I don't really know what to do with these adults. Like my experience with adults was like tongue and laryngeal cancer and strokes and stuff like in the hospital trauma center area, in like my training. So there was a gap in that. And so I really kind of wanted to see how, infancy, toddlerhood, early childhood looked like later on with some of these dysfunctions and disorders. And so that's when I was able to see entire families, which was very cool and still really cool. Like right now, we have three generations. We have a grandmother, the mom, and the grandson. Um, yeah, so it's so fun to get to know everybody. And then I'm a nerd. I had the goal of becoming speech pathologist, an orofacial myologist, and a lactation consultant. That was just like a goal, and I call it the oral function trifecta because it really does cover the lifespan and the functionality of the mouth and face. So I got that added to my name in 2019, and I was the first one in the world to get those three, which
That's
was
amazing.
kind of my little claim to
Trifecta.
fame. It was kind of
Yeah.
fun. Um, but anyhow, yeah, that's kind of my background. Right now, I have a private practice in Greenville, South Carolina. We have other therapists. We only specialize in feeding and myofunctional disorders. So we are very, very niche. And then, yeah, I do consulting and travel, to speak and do courses. So,
It's amazing. Well, and saying that you're treating multi-generational families is so incredible, but it just shows how little awareness in all of these things can is out there. Because if you're treating a grandma and a grandson, we're talking a 70-year span. And
yeah.
that's what we run into a lot is people saying, well, this is just a fad, like tongue ties are new. And it's like,
Mhm.
actually, your mom and grandma and you who had premolar extractions could have very likely oral facial dysfunction potentially ties that led
Mm.
to skeletal underdevelopment. Like, of course, there's the genetics, because, like you said,
Yeah.
apple tree, but we can control some of the controllables by improving
Mhm.
on the function as early as possible. But that's the cool thing, too, about those three certifications. And people ask that too. They say, well, why don't I see a myofunctional therapist? And they've got, their 2-year old. And I say, well,
Yeah.
right now you just told me that they're having difficulty with this articulation. And maybe it's who they're surrounded by. Maybe it's age appropriate, but a speech and language pathologist who has an understanding of myofunctional disorders is who
Yes.
you really need to be seeing in this moment.
Yes. And
Because if
like those
somebody's only
are
used to seeing 25-year-olds, they're not going to serve a 2-year-old very well.
right. And yeah, I also think they're still kind of rare and unicorns to find
So rare.
a speech pathologist that is trained in myofunctional therapy. And yeah, we don't do myofunctional therapy on that age. I say we do oral motor feeding therapy with applied myofunctional principles.
Absolutely. Yeah, just the
So
thought
yeah, it
process and
just looks different
understanding.
on that age.
Hmm.
You know, you have
Everything
some of the
does.
same
Like, they're
goals.
very much in charge. You can only control certain aspects of the behavior of what they'll listen to. I mean, the number of times I hear no from my kids in a day is just outstanding. So, but I
Yeah.
mean, that kind of plays into some of my next questions on therapeutic readiness. That's what we talk about a lot in our space as structuralists. Like, how can we optimize these outcomes surgically? And
Yeah.
I always argue, if there's no functional readiness before they walk into the procedure, it's almost not worth doing the procedure. We can cause more
Yeah.
harm than good. And we see so many well-intentioned providers wanting to learn a good surgery, but not having even the basic understanding of the mechanical principles and what's supposed to be happening. So I'm sure, because you treat all ages, that's going to look different for each age group, would you say?
For sure. So, kind of my evolution with that, yeah, I called it therapeutic readiness. And what was out there, in the beginning, back in my early career,
Dawn of time.
the mindset is, oh, there's a structural problem. I can't do anything until that's taken care of. And what I found was that I started thinking about big muscles, right? Like hips and knees and arms and whatever, and how applying that physical therapy model to the mouth and face. And I started thinking about, like, oh, okay, yeah, they do therapy before the surgery to get things as good as they can. Even in the dental world, they do orthodontics to get things as stable before they do orthodontic surgery.
Yep.
So, looking at that, and there were people out there talking about readiness when someone's ready for a release. And it was annoying to me, to be honest, because it was this vague cloud. Like, what does ready mean? And so I kind of started looking at what were the factors that I saw patterns with that helped outcomes. And
Mhm.
so, we don't want to like spin our wheels and do therapy forever, right? We want to, and get stability, get motor planning, um, prepare them mentally, emotionally. Some of those things are in there. And so I narrowed it down to 14 factors. And there are factors that are for everybody, that are common factors, that doesn't matter your age. These are the ones for you. And then I broke down factors for each age group. So, like infants, and then toddler preschoolers, and then older kids and adults. And so, is it going to be completely detrimental if they don't meet two of them? Probably not.
Mhm.
But they call it clinical practice because we're practicing. We're, figuring out what works and doesn't. And, what you did, a couple years ago is probably different than what you do now, and you've learned things.
Steps
And
better every time. Yeah.
yeah, for sure, for sure. Um, so that's kind of what that was. And I use the analogy because a lot of families that come to us, how many sessions? How many sessions do I need? Right? And, one thing I tell them is that depends more on you than on me.
Hmm.
You got to come, you got to do your homework, you've got to communicate, all of that. But, we talk about that sandwich approach, how we do therapy to get things nice and ready, and also as like a check and balance. Make sure we actually need the procedure, right?
Hmm.
And then the surgery and then therapy after. And so they're asking how many sessions, and or why? Why do I have to do something before the procedure? Like, can't they just fix it and then you rehab me?
Hmm.
And I basically tell them that it's sort of like an Olympic athlete that breaks their leg versus, someone, the couch potato, that breaks their leg. Who's going to do better with that surgical repair, right?
Hmm.
The person in good shape that has, good balance and their calf is good and I don't know, whatever else.
Just more
Um,
stability of the whole system.
right, exactly, versus someone that isn't there. And so they're going to have a much longer process on the back end because they don't have some of those foundational things. So that's what therapeutic readiness is in my mind. And yeah, I really like delineated that out just because it was on my nerves that people were like, are they ready?
Yeah.
What is ready?
And we get the same question on our end because you hear the questions that they phrase to you. We hear the questions they phrase to us. So, and they say something, how many sessions are they going to make me do? And I say, well, that's between you and them. I say the goal is to get a baseline and watch for improvement. Then potentially, maybe it's the third time you meet with somebody, it's back with me. But maybe you haven't made enough improvement yet. You got to see them a little bit more. Because
Mhm.
until you're doing a little bit better, have some strength and make some progress in the right direction, you are almost wasting your money on the procedure because you're going to have more scar tissue, more discomfort, less opportunity for change and improvement. Say optimal would be like you get the baseline, you come back, you're doing really well, you come to the procedure, you go back, see them again, get a new baseline because you have new structural anatomy. And
Yep.
then, yes, see them again and make sure we're still going in that positive trajectory. And then it's between you guys. If you feel and are finding value, which I expect you will, by meeting with functional providers, then keep going as long as you guys feel there's benefit. I think people want to put everything in a box and
A
have a
number,
checklist.
a
Yep.
number.
Yep.
Yes. How
And
many?
yeah,
And
we use the
what
same
you said,
analogy of the Olympic athlete. I just do it really basic, but then I need to change my verbiage because I say it to kids because it's easy to explain it. I say, you know what? Have you ever tied your shoes together and tried to walk around? And then over the last 2 years, I've gotten more, I don't know how to tie my shoes responses. And I'm like, oh, shoot. We only use Velcro now, don't we? Velcro and
or
elastic.
the
I'm like, I need a
slip-ons.
new analogy.
Yes.
Oh, have you ever Velcroed your shoes together? It just doesn't sound as cool. So
No.
I'm like, when we untie those shoes, we want you to have as much strength as possible going so you can take the fastest and biggest strides forward compared to the person next to you. And
Yeah.
trying to distill it down for parents to even understand because it can be so complicated.
Yes. Yeah.
Oh,
And especially since, a lot of their typical um, providers that are not specialized in this, you know, unfortunately, and maybe unknowingly manifest some of those, perpetuate some of those myths out there, right? And, or they just don't know, right? And so, helping them gain knowledge and giving them resources, that is not just me, but other resources, other than their general providers, has been really helpful as far as patient autonomy and, making their own informed decision.
for
So
sure.
I think that's important. And then something else you said jarred my memory. Um, you said basically like, "Hey, I'm not going to tell you how many sessions you need. That's not my lane." And that is so nice because then they don't come in with certain expectations and everybody is different. Like, that would be like me being like, "You need 2 years of orthodontics." I don't know that. That's not my thing. And so I don't
You
want,
know enough to be dangerous. That's what I tell families. I say, you know what? I know enough to be dangerous, but I'm a structuralist. I really
right.
want to get you in the hands of an expert who can really assess where you're starting. I can point out some of the muscle dysfunction, some of the tension patterns I'm seeing that are more big picture. But if
Yeah.
you want to make progress, I want you to see the specialist who really understands us. And I say, oh, isn't that my pediatrician? I say, do you know how much your pediatrician got on speech and feeding when they were in school? Say 0 to 1 hours is normally what they're gonna get. And there, I say pediatricians are so good at keeping our kids healthy and alive to the best of their ability with their knowledge. They don't have the
Alive.
time to specialize in the articulation of your R or know even where that sound comes from. So it's an interesting time in medicine where we're really trying to put the whole body together, but we're still also compartmentalized. So,
Right.
where do a lot of your referrals come from? Are they self-referred? Do you get a lot of from pediatricians, ENTs, dentists?
I would say it's a variety. I we do get a lot from orthodontists
Mhm.
because they're annoyed that hey, their work keeps failing and relapsing. And
Yeah,
so,
and it's wild because on our end, on the dental side, like they just posted something on a forum today where they were talking about overdiagnosis of maxillary, labial, and lingual frena.
uh,
And they then showed a case where they released a perfectly fine maxillary frenum. And I'm like, why are you displaying this case? Like, there's clearly
why?
no functional impact on this. This is adult dentition with no spacing. Like, I don't see anything in these static photos that would trigger me to be like, oh, red flags, we should release this. Like, this is why our stuff gets bad names because there's not even an
Yeah,
understanding on the orthodontic side.
right.
You definitely have some proactive ones in your area. We have some proactive ones in our area, but not
Yes.
everyone's as lucky.
And it's definitely been an evolution. Like I find that orthodontists and ENTs are the hardest ones on the team to like get them on
Well, they're
board.
so darn smart, right?
Yes. And like I feel like orthodontists are perfectionists. Oh, they want this angle, that angle, tweak this, tweak that. And like sometimes they don't see the forest because of those trees, you
Sure.
know? Um,
The
and
teeth trees.
so yeah, like we had some good cases that the patient self-referred to us.
Mhm.
And this one orthodontic group, I worked next door to them, like two buildings down, for 5 years. And I tried to like meet with them a couple times, and they were like nice and smiled and nodded their head, but they didn't get it.
Mhm.
And so this patient found me on her own, and they couldn't get her bite to close. She had already had a round of braces, and they were retreating. And basically, we did myofunctional therapy, got her tongue resting in the right spot, swallowing correctly, whatever. And she went back for like her continuous checks or whatever. And they were like, "What did you do?" And she like told them about me. And I got a cake the next week. So,
They're like, we're finally done with this case. Yay. We all
so
have
that was kind of the story into their evolution of like, I always say it just takes one case. It really does. Like, if you can show results with one case, like that's what people care about is results and that patients are feeling better and getting better. Um, so orthodontist and then ENT is a big one for us. We are blessed in that we have an amazing ENT. He lets me tell this, but I treated his child and he thought I was ridiculous. And his wife was like, "No, this makes sense. We're doing this." And she totally wears the pants. And so he went to a dentist that I was recommending, um, who did it with a laser, and he told her, "Don't tell anyone I was here." Because so many of the ENT world and colleagues like don't understand this piece of things.
For
And
sure.
sometimes I feel like they're doing such complex stuff, like super glottoplasties and laryngectomies and, removing throat cancers and stuff, that this is so so little. And like when you're a surgeon, like you want the cool big stuff.
Yeah. Well, even tonsils, right? Like
Right.
you've got huge tonsils and you've got not huge but still too big tonsils. What's
Right.
probably more fun to remove and on paper bad enough to take
Right.
out? Like they're all kind of the same thing. It's like if they're too big, they're too big. It doesn't matter if they're boulders or like slightly smaller boulders. They're still boulders.
Right.
But
Yes.
when we start to look at the things that you see in clinical practice every day, the the big stuff is kind of what the focus is on. So you see
Right.
something as simple, quote, as a tongue tie. It's like, maybe it's a problem. It's
Yeah.
tough. We
Yeah.
get
So
a
I
few
would say,
referrals from some that are like, you can do this better than I can because your instrument and your understanding of that anatomy is just different. But like, I'm
right.
not going in and correcting septums. So we all got
Yes.
our thing that we do.
Yeah, totally. And I think that's, different in different areas and whatnot. So yeah, back to your question, I would say orthodontist, one ENT practice, um, and then several, mainly pediatric dentists, a few general dentists, um, a couple of perios, which is kind of interesting to me.
Yeah, wild. Well,
Yeah.
I've been seeing more and more lingual recession in relation to Eiffel Tower. And you can't
Yes.
graft that. You can't put bone there. Like the
Right.
chance there was some trauma or crowding and the bone wasn't there to start, but then you couple that with that pulling from that attachment and
Yep.
it's really damaging. And like you're going to lose a tooth.
Right. And it totally, I'm imagining that it kind of creates a hygiene trap too with those flaps there.
Oh
And
yeah, you can
so,
just see it that like rolled mucosa not attached. I
yeah,
was doing one on a dear friend the other day. She had a low labial and it was just pulling so much and the periodontist actually was like go and have this released because it's putting too much tension. You're probably going to need a graft one day, but I was able to get in there with like a little micro brush and clean where she hadn't been able to just
yeah,
because it was so like and it hurts and you're also worried about the tissue. Like patients are scared of losing that tooth or causing
yeah.
it to be worse. So
Yeah, good. They're getting on board.
yep, little details.
Yeah, a couple that we have, one we treated his son and his wife, so he like got a front row seat to it. So that's what I'm saying is like I feel like a lot of personal experiences, and that was kind of for you too.
Yeah.
Once
Like
you,
all of us in this space, at some point you've been touched by it, right?
right,
See a
yes.
success in one of your patients or in one of your family members, and we all have this aha of like, oh, that makes sense why that didn't work 3 years ago when
Hmm.
I tried it. So
Yes. Yeah.
it's so wild. But I mean, you've definitely seen evolution, not only in your own clinical practice, but in this field. So, kind of had some aha moments where you were seeing it and then beginning to implement it in clinical practice, seeing the progression of your career, and then also going into that career path and those training certifications with the knowledge that tethered oral tissues exist, I'm sure put you in a different lane than some of your other colleagues who are going through those programs. Do you find that the conversation on tongue, lip, buccal ties is part of a curriculum? Is it skirted over? What are you told in practice these days?
I think it's definitely changed, for the better, mostly. Um, I think people are more aware. It's not like this, you have to go down this rabbit hole to find some of this information. I think, courses, more research, even, podcast,
Mhm.
information is so much more accessible than it was 15 years ago or whatnot. So I do think that's had a positive impact. Um, what I find is people have these credentials, and even me. So SLP, lactation, um, myofunctional therapist, they have these credentials. But I always say, like, an SLP degree doesn't mean you know tongue ties. A
Mhm.
myofunctional therapy course or certification gives you that overarching. It doesn't give you the specific tongue tie stuff. And same for lactation. Like, even with lactation, well, even with myofunctional therapy, there isn't a set curriculum.
For sure.
So like you can piece it together. Um, yeah, like for example, lactation is like 95 continuing ed hours, and it depends on what pathway. You are an IBCLC, right?
No, I'm not. That's one of my dreams one day. I
Okay,
have a few
maybe that's
projects
where I
I'm
heard it.
launching first, and that's it's
Yeah.
I thought about it to start. I said, "Oh, wouldn't this be so valuable?" But then I thought to myself, I have things that I do that if I know too much, I'll give away maybe information that I shouldn't be, right? Because I don't have all of the information I need to really share with the family. So until I can put the time and the dedicated energy into getting a broader sample size than what I see, because like I
Mhm.
could use my clinical patients as hours, but I
Yeah.
would want to just like take a month of shadowing everyone I could and garnering different hours
Hmm.
in all sorts of different settings, because that's what I tell families too is my practice is biased towards dysfunction. Like the babies that are coming in here, the patients that are coming into here,
They got
somebody
problems.
has raised a concern about how adequate their function is for what we're trying to accomplish goal wise. So of course, when I look at those structures, I'm going to equate it to, but I also see some babies that come in that though their function isn't optimal, their anatomy doesn't seem to be impaired. So
Right.
I'm really good at assessing structure and then relaying that to function. I want
Hmm.
to get better at assessing for function so that I can give even more information. So that time will come one day.
One day.
Well, I'll
One
find out
day.
another trifecta. I know there are dentists, DMDs, IBCLCs out there, but I got somebody's got to come up with some other letters so then I can go.
Yeah, totally. There's so many out there now. I'm done. I am
You're
done
done.
with
She's done.
I'm done.
Too busy.
It's enough to like keep up with them, but
But hold on, hold on. You're not done because, like, let's think about all your course names, like the E3 model of care. Like, you're making up your own letters.
yeah, I mean, definitely like a model of care and terms and stuff. Letters would be, you'd have to like do a whole exam and have a board and whatever to have
For
like
sure.
a credential of it. And I have
Yeah.
no interest in policing people.
I like the trifecta. Like, you don't want to call it a quad, it's just going to sound boring. So,
That's true.
but I mean, because of people like you that are really going out there and learning more and more and more, and then equating that to this practice of medicine, of clinical care, that's kind of driven a shift. And again, that's what I saw at your course was people seeking more knowledge
Yeah,
because, like I said, in a myofunctional course, you don't learn tongue tie. It's a myofunctional course.
right.
It would be so nice if one day we really had, and we're getting there through research, through numbers, through standardized measurements, varying degrees of normal, what compensation patterns are. So it's nice to see the shift happening that way on the research side of things. But I think for a lot of us, it's tough to say, oh, research is going to drive treatment all the time because there's so many factors.
Yes. And that's the big thing. Like, I'm so grateful for people out there doing research because I mean, I don't have the time to put that together or, the IRB and all of that. And I feel like a lot of the research out there is not by people that literally have their hands in people's mouths, right? They're just like scouring the articles and, that's okay. And that's research that's needed. But like you said, like there are so many variables. Okay, what was their baseline measurement? Who and what training do they have to put that baseline measurement?
Mhm.
I mean, for gosh sakes, we don't even have a uniform definition of a tongue tie.
Hmm. Hmm.
So how can it's just not apples to apples. We have different methods of releasing. We have different aftercare protocols. Did they have therapy before and after? Did they do body work or not? Like there's so many of those variables, right? And you can't control for all of those.
No, because we can give clinical recommendations, but I tell families, I tell my team sometimes, I say, you know what? I can't drive them to the chiropractor's office or the osteopath's office, and I can't pay that bill, and I can't do this. I can tell them why I feel strongly there
Right.
is benefit to this. But if they don't see the merit to it, they're just going to see that it doesn't work for them, right? So
Right.
yeah, we
And that,
can there's so many things that are hard to standardize in the human race. You just can't withhold stuff. You
yep.
can't guide everything.
And we're never going to get there. We're going to discover even more variables down the line, right?
Oh, there's so many. Such a
Things
rabbit
that we're
hole.
talking about now were not things that we talked about, 15 years ago, right? And so they've become factors when more people have practiced and whatnot. But yeah, back to your question about how the field has kind of changed. Um, I do see more people like hungry for the information. And I, I do see people seeking it out. Um,
Do you think
and
it's
not,
parent driven? Do you think it's like general public driven? Do you think it's
I
provider
I
driven?
think it's both.
Yeah.
I think it's personal experience sometimes. You have your child has problems, right? And then you go through it and lo and behold, it helped, right? I think people really take it personal and get fired up, and it just makes them very passionate when they have, you know, probably even unknowingly by these providers kind of been gaslit and dismissed, and they'll grow out of it, and there's no credible research, and this doesn't affect that, and it's a fad and whatnot. And so I do feel like people are very passionate about it because they weren't helped, you
Yes.
know? And
Yeah.
so I do think that social media, um, obviously more research coming out. Um, I do think there are a few grad programs I know that are teaching a little bit about tongue tie. And that's the thing, like you need like a dedicated course, right? Because the bigger curriculums just can't cover the nitty gritty and the nuance of it.
And there's so many things that they have to get through in order to keep their
Right.
accreditation. And we were having this conversation with Jeff Rouse a few weeks back, and I said, "Do you think in 5 years we'll see airway dentistry taught in school?" And he goes, I don't think so, because we have so many other things that when you're
Right.
trying to get a DMD, a DDS, an SLP, a master's, or whatever, that there's a lot of red tape and hoops and boxes that have to be checked,
I
and this
mean,
just isn't one of them.
it would
So,
be, 3 years longer if you did, you
and
know?
think of how much time and money and energy you have put into becoming who you are. And I think that a lot about myself when my
Yeah.
accountant goes, you know, "Are you sure that CE number that you
It's
spent
worth it.
this year is right?" And I was like, yeah. He goes, "I've never seen a number like that before." I'm like, I had to get it all. I had to get everything in 1 year because I couldn't learn it fast enough. But not everybody wants to do that, and that's their personal choice. But it's hard to, when I ask that question like, about, is it patient driven? Is it provider driven? I just see so much of the parents really looking more towards preventive care versus kind of the reactive form of medicine that we've been living
Yes.
in for the last
Yep.
30, 40 years.
Yep.
As there is more information out there on like, hey, we could actually prevent certain things from happening. Like,
Right. And there's
let's
the
prevent diabetes or heart
right.
disease instead of just like waiting until it happens. So,
Yes. And there's a lot more people, I feel like, looking at, insurance is kind of a scam.
mhm.
And
Well,
so
it's
they're
hard.
looking at root causes, not just here's a pill, here's a CPAP, you know, stuff like that. I think people are really looking at underlying issues now, more so than in the past.
And it
So
can be
yeah,
expensive up front, but if you think about the longevity, you think about what can come from
yes.
optimizing a system in childhood, even from a functional perspective. Like back to the orthodontic conversation, like all
Yeah.
orthodontics is pressure on teeth. Well, what's
Right.
a tongue thrust do? It's tongue pressure on teeth that's as dramatic as orthodontics that can move teeth in the opposite direction that you just put
Yes.
them into orthodontically. So
Right.
people are like, well, I don't want him to have braces twice. I'm like, well, like you just told me that you've already had 2 rounds of Invisalign as an adult. and your childhood braces at 13. So you've already had orthodontics 3 times because the foundation wasn't stable. So I think we're just working
Yeah.
to do better for our kids because we have
Yeah.
so much more information.
And definitely like, seeing those cascade effects, like you can draw, I call them breadcrumbs of like, okay, you had a bunch of reflux when you were a baby.
Mhm.
Oh, you had trouble learning to chew foods. Oh, guess what? Now you have a lisp. Like, all of these things down the line. And, one of the things, we do talk about is it's an investment,
For
you
sure.
know? So, yeah, I say the exact same thing you do. Everyone only has so much time, money, and energy.
Mhm.
And, some therapy is better than no therapy.
Yep. And I think that is the hard part in our fields, like we can become so siloed into perfection. But at
Yeah.
the end of the day, we're working with human beings. And I think that's where I really try to relate to families of like, I am an adult who should be doing myofunctional exercises every day. And I don't because I run out of time and
Yeah.
bandwidth and thoughts to
Yep.
invest in myself. I have 2 children who I own who have all the things that we work really hard on, but we're not perfect because we can't be, because we still have to exist as human beings. There's only so much time, money, and energy.
Yep.
So trying to meet families where they're at, I think is so important. So kind of back to the readiness, like everybody's readiness is going to look different.
Right.
It's therapeutic if you're making progress. And
Yep.
so we can't hold everybody to the same standards for everything. We just do the best
Yes.
we can with the canvas in front of us.
Yep.
I
And
don't think there
what you
is such
said.
a thing as perfect anymore. Like our skeletons aren't perfect. There's too many variables now from the genetics, the nature, the growth, and just what our goals are too. Like,
Mm.
my goal isn't to go out and like hunt my food and then eat it over an open fire. But like, I'm sorry, I'm going to Costco and buying some things that are prepackaged because, again,
Right.
bandwidth. Maybe it's not the best for jaw strength and development, but we do the best we can with what we have. So,
Yes. Yeah.
oh, it's
And
so hard.
once I had, before I had McKenna, my daughter,
How old is she now? Is she 13?
no, God, no, thank God. She's 8.
She's 8? Oh my gosh. I don't know why I thought she was like in her teens. She looks so
No,
grown up now.
she does. Yeah.
Oh,
Um,
so hard.
but yeah, like before I had kids, I was like, why aren't you getting these exercises done?
Yeah.
And now I'm like, I know, because your house might be chaos that
Yeah.
week.
Uh-huh.
And so, we really work on meeting them where they are as far as like, okay, you said you didn't really get them done this week, and that's okay, right? We'll hop back on it for next week. And if it kind of becomes a trend, then we're like, okay, tell me about the your routine in your day.
What can you do?
And yes, like let's find little pockets of time, whether it's breaking up the exercise, where it's doing less, whether it's, multitasking. So yeah, I think that's very important, like you said.
Well,
Um,
there's some burnout with all this too, right? Like how many of your have your clients come and see you and they're like, I've been in speech therapy for 3 years. And now all of a sudden I'm learning about myofunctional therapy.
right.
Like they're burnt out, they're kind of irritated. Like,
Irritated?
yeah, like all of us kind of want to be done. Like if I could find a quick fix for everything in my life, I'd be psyched. But it just
Right.
doesn't exist. So I also tell that to adults. I say, you know what, if you're not ready to do some of these exercises, like don't do this now. Like you've been
Right.
like this for 37 years. What's another 6 months? Like find a
Right.
better time. Go to on your vacation that you've already planned. Like do whatever
Right.
you got to do so that you feel like this is a good time for you to move forward.
Yes.
Um, I mean, kids are just more time sensitive because there's so many things happening in terms of like
Yes. And what you
communication
said,
and
like some of the preventative stuff, like I always say it's much easier to direct growth than to like try and generate it, you know?
absolutely. Yeah.
So yeah,
Well,
it's easier.
I love the mandible. I don't know. I just love it. I love it so much. All my friends love the maxilla and I think it's so cool, but I'm a big mandible fan. And I think part of it is I think about the mandibular growth that happens from tongue extension and primitive reflexes, reflexive swallowing in infants. And if we don't get that extension, that like primitive tongue thrust, we're going to miss on a huge growth opportunity. So I'm like, no, I don't want the tongue thrust to stick around. I want it to
Right.
habituate and become what it's supposed to. But like those first 3 months matter so much.
Yep.
So yeah, it's growth is easier to guide than it is to alter reactively. Because like
Yes.
class two elastics, like, are we actually growing the mandible? Who knows? Maybe some, maybe not a lot. So why don't we try to get those extra few millimeters at birth instead of at 12?
Yep.
It's hard.
Yeah, totally. And some of my friends, of course, I don't say anything till they ask.
Of course.
Um, oh
It's so
God.
hard.
One, her ultrasound photo, oh my gosh,
Oh my goodness.
that chin was so far back. And I was like, oh.
Oh my
And then, of
gosh.
course, he was born with a tongue tie, and she called me from the hospital.
Don't worry, I'm planning something. So my sister's pregnant. She's due May 10th. It happens to be my daughter's birthday and her husband's birthday. So
Oh,
he already lost his birthday to my daughter and Mother's Day. And now he's probably going to lose it to his third son, of which they want a daughter, but they're absolutely having a boy. I just know it. So the gender reveals this week. At her next ultrasound, I'm going to get measurements. And then when the baby's born, I expect that I'll be invited to the delivery room so that I can ultrasound the joint on first latch. And then we'll do
oh,
some body work and then
that's
we'll do some
cool.
functional therapy. We'll keep ultrasounding the joint. I'll basically just follow her around for like 3 weeks. And then, of course, it'll be born with oral restrictions, as both her
Yeah.
husband, herself, I don't think her husband knows he has one, but he does now if he listens to this, and both their children have. So we'll just kind of keep making modifications and then keep imaging to see what changes. Because if we can get some of this on paper, it'd be great.
Right. And that is so difficult to do because, like new parents, they're tired. They don't want to go to the clinic every, week or whatever to do this imaging. And that's why it's so hard to get like that hard data over time.
For
And
sure. But
so
when it's
thank you
family,
for
I
doing
mean,
it. Exactly. You're
gotta
going
do
to
it
be
for
following
me.
them around anyway.
Yeah, like I'm not gonna invite her to Christmas if she doesn't do this. So, like, goodness.
Does
See
she know
what
of
your
this
kids
plan?
get for their birthday. So, with her first, it was kind of the same thing. So her first was born, and I was like, oh, he's got a tongue tie, like this little
Yes.
sweet squished head. He was so squished. And I didn't say anything. And finally, she was like, so do you think he has a tongue tie? It was like 2.5 months in. And so we did
Hmm.
all the things as quick as we could. And things went really well. But like overall, still growth, a little compromise. So we're doing some modification stuff. Then her second one, she was like still pregnant, still in there. And she was like, so you got to tell me right away if there's a tongue tie. And so, like, the second he was born, I look at her and she looks at me and she goes, don't say it. I'm not ready. And I was like, okay, cool. Brakes are on. Brakes are on. So like 3 days later, she was like, what do we got to do? So,
Yeah.
so wait for your
And
invitation before you speak up. But
that's right.
this one, I'm
Exactly.
just gonna like crawl right into her womb first before she has a chance to stop me. It's gonna be
She's had
fun.
two other go rounds. It's
Yeah.
fine. You're
Like,
good
yeah,
now.
it's good. She's even finding out the gender for this one. She's letting me do a gender reveal. It's gonna be a big deal. So,
So you think it's a boy?
I want it to be a girl, but like odds are it's definitely a boy. She's doomed. She's destined because they're wild. They are those wild, like rock jumpers where like your heart is in your throat anytime you're around them because you just think like bones are going to shatter, yet they never do. So she manages it much better than I would as a risk averse human being. But
You have a daughter and a son?
I do. Yep.
Are, aren't they
My
so
boy,
different?
his recent claim to fame is he got to go on stage with the Ninja Kids, who also, if you've ever followed the Ninja Kids trajectory, like I have been blessed to over the last 3 months because they're obsessed. It's the only YouTube thing they're allowed to watch. These kids had early orthodontic intervention. Like at 8,
Oh,
everybody in their show has the same expander and the same 4x4 braces. And I'm like, way to go, Utah. You're ahead of the curve. So my boy got to go on stage with them the other day, just serendipitously. His name's Paxton. This other kid's name's Paxton. And I'm like, Paxton, one, if you had expansion at 8 and my boys already had like 2 rounds of expansion by like 7, then like anything's possible. Maybe next you'll be doing backflips on stage. So,
yeah.
and then
You
my
guys
daughter is just
can be
like
friends.
little Miss Adorable. Both of them have been blessed with a dentist as a parent. And so they will continue to drink my Kool-Aid for as long as they
And
allow
then
it.
you did Marpy, right?
I have had a Marpy. Yep.
Yes. So then they won't have to do that, hopefully.
That's the hope. But
Yeah.
like, in the search for perfection, will they, Autumn? That's the question we don't
Yeah,
know.
there's genetics and then there's epigenetics,
Yes.
and you can
Yes.
control for as much as you can, but we'll see.
And then my sweet, sweet husband with his narrow vaulted palate and his sleep apnea. So we'll see. We'll see where the dice land. But because yeah,
Yep.
you've been through adult expansion as well. Like I'm still finishing up
Yes.
because I'm quite lazy and trying to get to Seattle. It's where my providers are. Takes more time than
Who
I
are
set
you
aside.
seeing? Rebecca?
My dear friend Rebecca, who
Yeah.
I do a lot with her virtually because she's amazing. Becca Buckow, who is
Yep.
like such a champion of orthodontic protocols that change growth positively. And she gets like, I will say, I'm going to use the word shit on my podcast. I don't know if I'm allowed to do that,
She
but she gets
does at the
shit on.
AAO. Oh my
But
gosh.
then you got men standing up saying the same thing and they don't get a peep. It's like maddening because she's publishing, she's speaking, she's putting herself out there. And same
Same
thing
for
with Audrey
Audrey
Yoon. They're
Yoon.
both incredible. And
Yep.
I just like, I remember the first time I ever heard Audrey speak, she said, there's this orthodontist just trying to be like, what about relapse? What about relapse? What about relapse? About expanding on primary teeth. And she goes, I will never let a child be sick because I'm scared of relapse. And the whole room went silent. And I was like, mic drop moment. And then the guy
Mm.
afterwards comes up. He goes, so like, how do I do this with my three-year-old grandson? And it was like, okay, cool. You won't do it on your patients, but you do it on your grandson. So Becca and then Greg Kinzer and Jim Janikowski, both restorative dentist and periodontist. They're incredible. I have a bunch of like complex restorative because I knocked my teeth out when I was a kid, but it really just masked the fact that I had like maxillary underdevelopment because we were able to like put things restoratively into a position where they looked fine. And then under the
Yep.
surface, you realize, oh, it's not just about straight front six teeth. I think that's the hard part with orthodontics is like, let's line up a smile and expect it to be functional
Yes.
for a lifetime. And it's not always a reality.
Right. Yep.
So,
Totally.
but it's
Oh
also
boy.
not orthodontic's fault. If like the function didn't lead to the bone development, then they don't have a great foundation to build that house on either. So it's
Anyway,
not like it's their fault, but it's all the faults of human evolution. So
absolutely. Yeah.
well, what challenges do you find that you are facing right now in practice? Or do you guys feel like you got a good thing going, like referral wise, patient wise, information
We
wise?
we have such a great community, and like a lot of that's come from just networking. Like we have 42 regular referral sources.
Amazing. That's
Like that's huge. So I feel really good about it. Um, I feel like some people are very like gung ho at first and then it just like trickles off. And so, you kind of have to like maintain those and continue educating and, more touches. Um, I think the economy plays a role.
for
And
sure.
yeah, I mean, when people are nervous about, certain things, whatever's going on, um, they're only doing what they consider is necessary,
Yep.
right?
What the bandwidth
Um,
is.
right, totally get it. And so I think that can sometimes be a challenge off and on. My favorite one is, oh my gosh, some of these parents are like, I want to start in the summer because I'll not have school
So
to
much
deal with
time.
and routines. I want to start in the summer. Okay, fine. But then the other people are like, "Oh, summer, we're going here, there, and everywhere. I want to start in the fall." And so like the scheduling is definitely tough.
Yeah.
The other thing you said was like basically, you can make these recommendations, but you can't make them go. And so, that follow through is hard when we're like, hey, we need so and so's help to like get a good outcome.
Mhm.
Um, so yeah, I mean, that's just the nature of having a practice and working with
Yep.
people.
We're trying
Um,
so hard to just keep the line of communication available. So if there
mhm.
are questions, like I walked out of an appointment this morning, I was like, well, that was a lot of information. What do I do again? I was telling my husband, I try to give like a one page that they walk out with. Even if we need to refine it later, I'm like, step one, step two, step three, step
Right.
four. Like I call it our choose your own adventure based on their chief concern too.
I it.
Because everybody's got a different chief concern. So I just start all of our consults with if you could wave a magic wand and change anything right now, what would it be? Because
Right.
maybe you've got a speech therapist who's concerned about articulation, but the parents think it's adorable and they don't want it to change. Like they're not going to go through with
They're
therapy
not
because
going to work
that's
on
not
that.
their goal. But if their
Yeah.
kids like spitting food on the table, that's their concern. So like how do we phrase it to help
Yep.
families understand how wide-reaching all these things are? Um,
Yes.
it's
Yeah.
tough. It's tough to get that kind of contact and constant contact with them to keep them engaged.
Right. And yeah, it is tough too. And this is why mainstream medicine isn't this way,
Hmm.
because it takes a lot of time and coordination and phone tag and, not just phone tag with the patient, but phone tag with other providers and,
Hmm.
reading a lot of reports and emails and
Yeah.
stuff like that. Like it does take a lot.
Well, that's the beauty of referrals, right? Is because like you know what their thought process is and they know what yours is. Because patients are always
Yes.
like, do you need their clinical notes? I say, they're valuable.
Yes.
But what you tell me that they told you is equally as valuable because they're going to give you the bullet points that really help me tie
Right.
everything together.
Right.
I mean, and also if you've worked with people long enough, you know what their focus is. Like we have
Hmm.
certain myofunctional therapists who love a certain thing and speech therapists who love the R. And so I know that they're there for a reason just based on what that person's like interests are in their person in
That's so true.
their space.
That's
So
very true.
it's yeah, it's so fun though. And I mean I'm sure as you've seen as your practice has grown and like other therapists have come in, the day-to-day collaboration is you learn so much from each other and just
Yeah.
sharing cases, seeing them through different lenses. It's fun.
It is fun. Yep.
Yeah.
Super happy
So
to be
break
doing
down
what
your
I love.
courses for us. So for people that are listening, because what I'd love to do
Gosh.
is get more speech and language pathologists to you just because I see there's a big deficit in my community. And I'm
Yeah.
sure that people nationally listening would say the same. What are your course offerings right now?
Okay, so let's break it down. So our flagship course, TOTS training, tethered oral tissue specialty training. So that is my model of care, all the nitty-gritty ins and outs of tongue tie from, evaluation, getting everyone on the same page, and then, completing a treatment plan and seeing it all the way through. So that's flagship course.
And Dennis, I
Um,
learned so much from that. Again, that was one of the first courses that I went to. And I think going into further training with a better understanding of the function first was so beneficial.
oh, I love dentists like you that think that way. Um, okay, so that's one, and then we have the Stones approach. So that's my advanced myofunctional therapy course. It's systematic treatment of orofacial myofunctional disorders with nuanced effective strategies.
Wow.
I know it's a mouthful. That's why it's
Amazing.
called the Stones approach. So it's kind of like a framework and how to individualize treatment because you need sort of like a path, like an overall like framework, but everybody's different. How they learn is different. How you have to adapt exercises is different. What you do and when and how you make those decisions. So, like, for example, when I came out after my initial Myo course, I was like, I have all these exercises and I know I'm supposed to get the lips closed. And so, I need to get them to do a taco tongue, but they can't do a taco tongue. So how do I get them to do a taco?
What
Right?
do I do next?
And so, yeah, it was just so unclear and jumbled. And, you know, intro courses just can't give it all, right? And
Nope.
so this was kind of what I felt like was missing when like I was practicing Mayo and I was like, okay, what's next? And so we don't really have a lot of info on TMJ dysfunction, orthodontic surgery, all the different oral appliances. And then one of the big things that people want to know is, do we do a release first? Do we do expansion first? Do we do ENT surgery first? Like, what comes first? What comes second? And like, what are your indicators and decision factors for those? So anyway, that's the advanced Myo course. And then we have a few mini courses that are just like you get them and they're on demand and you have them forever.
That's awesome.
So one is confidently connecting for collaboration. So that's literally how we built our team. So
Mhm.
what strategies did I use? What secret sauce? Um, Magic to get this whole team going. Then we have Guide to Becoming an IBCLC. So honestly, it's really confusing looking at their website and the certification
Yeah.
requirements and how to figure out what's the difference between a CBS and a CLC and an IBCLC. So it's kind of like breaking it down to figure out what people want to do. We have another little tiny one that is, it's called Is Myo Right for Me? And it's for therapists that like they're kind of seeing some myo concerns, but like, how do I integrate some basic myo into what I'm already doing
For
if they
sure.
don't want to go down the whole big course, right? And then the therapeutic readiness course.
That's
So,
awesome.
yeah, another one's about to go online. So
Can you
anyway,
share what it is, or is it a surprise?
I think it's going to be a surprise.
Okay, well, keep us
So,
posted when it is. All of
yeah,
these
it should be
courses
this
will be
fall.
linked, so make sure you check them out. I mean, even just listening to your description of like the Stones course, I just want to be on a fly of the wall and listen. We just learned so much through collaboration, and I think that's what people ask a lot too. They're like, "What? Why do you work with other providers?" I say, "Well, because it makes everything easier and better. Like it makes your day to day easier for
It does.
sure because it's
It
less
does.
education. It's already been done. And then you're
Yes.
hearing it multiple times. Because what do you have to hear something a number of times before it really
Right.
sticks? And patients are no different. So,
Yes, for
oh, well,
sure.
Autumn, this is so fun. I'm so glad to reconnect. Are you going to be in Las Vegas in February
I'm
at
not.
American Laser Study Club? Where will
I'm
I see you
not
again?
this year. I don't know, girl.
I don't know. I just
I'm
got to come to
figuring
you.
I'm figuring out my 26, 27
It's
conference
hard. I mean,
weekend
kids
schedule.
definitely play a factor in limiting
Yes,
travel. Like I was so much more like, I'll go here, I'll go there. And I'm like, if they can't come with me,
I
then
know.
it's hard to leave them.
It's been harder as she's gotten older, honestly, because she's like aware
I
that
know. Don't
mommy's
you love the
gone.
Mother's Day presents that are like, mommy's good at working? And you're like, what's daddy good at? And they're like, golf. I'm like, daddy works too, but like he also golfs a lot. So,
Right, right, right. I know. I'm with you, girl.
oh
I'm with you.
man.
I could talk to you forever, man.
Oh, makes me giggle. Well,
Oh,
thank you so much for doing this. Everybody, please follow Autumn over on her social media pages. They're linked here. Her courses are linked here. I truly cannot say enough good things about what you've done for bringing awareness to everybody in this space. And I just appreciate you so much for taking the time.
oh, back at you. Thank you so much.
Yeah, girl. Well, let's do this again sometime soon. We'll do a repeat once you launch your other course. How about that?
Okay, sounds
Ooh,
fun.
a cliffhanger. I can't wait to know what it is. All right, I'm gonna stop our recording. Bye, Autumn. Thank you.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this, and don't forget to subscribe.
want to learn more about airway health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram at Untethered Airway.
Until next time, bye.